Hello everyone, my name is Erica Miles, and for my Capstone project, I did a systematic review on the effects of fruit and vegetable prescription programs on consumption of fruit and vegetables in food insecure children and adolescents. So the objective of this review was to understand the current research on fruit and vegetable prescription programs and its effects on fruit and vegetable intake among food insecure children aged 2 to 18 years old. We also wanted to assess whether financial incentives promote higher fruit and vegetable consumption. And it also can see if it provides healthcare providers and families with the findings to increase fruit and vegetable intake. So to the introduction, in the United States, inadequate fruit and vegetable intake among children is a significant public health concern. About 29% of this population does not have the 5+ servings of fruit and vegetables a day, and they do not meet the USDA federal dietary guidelines. Some factors could be because of cost and affordability, availability and access to it, and environmental challenges, specifically in low-income and food insecure communities. The reason this is so important is because there's so many benefits to fruit and vegetables, and which include growth and development, overall health, disease prevention, risk of obesity, and even into adulthood, psychological well-being, and gut health. 40% of the daily caloric intake among individuals aged 2 to 18 years old consume ultra-processed foods, added sugars, and sugar-sweetened beverages, which is decreasing their fruit and vegetable intake. In the older youth, 14 to 18 years old, only 7% meet fruit intake guidelines and 2% only meet vegetable guidelines. And then data from 2015 to 2018 shows that the percentage of fruit and vegetable consumption decreases with age and income, and this decline is primarily due to food insecurity. Food insecurity is a condition that limits our access to adequate nutrition as a result of financial constraints, economic challenges, or insufficient resources. In 2020, food insecurity affected about 13.8 million households, and also 20.6% of low-income families experience food insecurity. So to address these food access and availability challenges in food insecure communities, fruit and vegetable prescription programs, or FVPPs, have been introduced. This is an initiative to provide individuals with access to fruit and vegetables. Many programs differ in how they're ran and operated and designed, but they're generally done by an individual or patient being prescribed a voucher or an incentive by a healthcare provider, and they redeem these at participating retailers, which can consist of farmers markets, grocery stores, online companies, delivery companies, or mobile markets. By offering financial incentives, FVPPs aim to support increased nutritional intake. So for our research question, in children and adolescents aged 2 to 18 years old living in food insecure households, does fruit and vegetable prescription programs offered for at least 3 months affect fruit and vegetable consumption compared to children who do not participate in these programs? So to answer our research question, we started looking at databases through PubMed, Scopus, Embase, ProQuest Central, ResearchGate, JSTOR, Medline, and Public Health Database. We searched terms such as pediatrics, children, adolescents, youth, food insecure, food security, and low income, fruit, vegetable, produce prescription, food voucher, incentive program, wellness program, produce prescription program, and then fruit and vegetable prescription program. We looked at dietary patterns, fruit intake, and vegetable intake. And then here is our PRISMA guideline. You can see we started with 1,918 records through exclusion criteria and screening for title and abstract. We have 14 studies included in this review. And then our exclusion criteria consist between 2018 and 2025. It had to be greater than 3 months exposure. It could include parent-reported surveys, The measure outcomes had to be on fruit and vegetable intake. There had to be more than 10 participants, aged 2 to 18 years old, living in low-income communities or food insecure households, free living, community dwelling with no chronic illnesses or camaraderies, but they could be at risk for chronic diseases related to obesity or have obesity. Also, only English articles. Exclusion criteria consisted of resources that were duplicates, no systematic reviews or meta-analyses, if there was less than 10 people in the study group, if they didn't show results, and then age of study subjects were older than 18 years old, if they had chronic illnesses, or if they lived near food secure in high-income communities. So through our 14 articles, we found quantitative articles, mixed methods, and qualitative articles. We included all of these in this review. And then I'm not going to go through each one, but you can see here we've had 4 from Sachs Cusack who did a lot of research on this. She had one of 6-month exposure. She had 2 years of exposure. And then she also had another one that included blood pressure, also dietary patterns. And then another one to note was Jones, who had young Navajo children. And then Esquivel also had Hawaii. Theirs was done in Hawaii. And then Hager, they did a multi-site evaluation of 9 produce prescription programs all throughout the United States. And then mixed methods, we had At-Risk Pediatrics by Lee. Fisher had for at-home delivery produce prescription. And then Mulita had just about nutrition-related behaviors. Qualitative primary articles consisted of caregiver perceptions. And then there was another one in Hawaii done. And Burrington had an online produce market. The study designs for the quantitative articles were secondary analysis, non-controlled longitudinal interventions, pragmatic evaluations, cross-sectional analysis, community non-randomized prospective cohort study, and a multi-site pre-post evaluation. And then qualitative data that we got was from focus groups, semi-structured interviews, in-depth interviews, surveys, and photo voice. Locations consisted of rural and urban areas all throughout the United States, through Connecticut, Maine, Massachusetts, New Mexico, New York, Michigan. There's about 3, I believe, studies in Michigan, Utah, Arizona, New Mexico, Hawaii, and then Washington, D.C. Population and demographics consisted of children aged 2 to 18 years old. There were articles that had caregiver child dyads between 82 and 680. There were also, as a caregiver with 2 or more children, basically families with 25 to 82, only children, 125 to 1,817. And then the children were healthy or children with overweight and obesity and could be at risk for obesity-related chronic diseases. The race ethnicity were African American, Hispanic, non-Hispanic Black, Caribbean American, non-Hispanic White, Alaska Native, American Indian, and Native Hawaiian. And then for the intervention, that was all programs had fruit and vegetable prescriptions that were distributed to their participants in exchange for fruit and vegetables at participating retailers. But they differed in how much money was given to these participants. So you can see down here these were all the different allotment of money by household size, 50 cents to $1 per household member per day, $15 of prescriptions to patients after each office visit, and that was in about 3 studies, $1 voucher per household member per day with a max of $5 per day. There was one that gave out $50 a month for 6 months, 300 total vouchers. In 3 different studies, it was given out $63 a month, $60 a month, and $24 a month for 3 months. There was also weekly online credit of $15 for a family of 3, $20 for a family of 4, and $25 for a family of 5 or more. 2 studies gave out 8 pounds of fresh fruits and vegetables every 2 weeks for 12 months. And then another one gave out $10 after every healthcare visit. So this could have affected the results. Now for the fruit and vegetable intake quantitative outcomes, it showed that 3 studies found a significant increase in total fruit and vegetable intake. 2 studies showed a significant increase in vegetable intake, and 1 study found a significant increase in fruit intake. And then 1 study looked at starchy vegetables and found a significant decrease by 0.3 cups. I also thought it was important to note that there were improvements made in studies, but there was no association. There was no significant difference. So in 3 different studies, they found improvements in fruit and vegetable intake, total fruit, and total vegetable, but no statistical difference. And then 2 studies looked at fruit juice and reported mean daily intake had decreased, but again, did not show statistical difference. In 2 studies, they found no significant difference or improvements in fruit and vegetable intake and fruit intake. And then here are the graphs that we could see here that we'll just look right here. Servings of fruit and vegetables increased at end of program, but there was no significant difference. And then fruit intake increased and vegetable intake increased. In 1 study, it showed a significant difference in mean change of daily fruit intake when comparing fruits by race ethnicity. It showed that African American children reported a mean decrease of 0.32 cups of fruit a day, and white children reported a mean increase of 0.21 cups of fruit a day. But in the 13 other studies, there was no significant difference between race ethnicity and fruit and vegetable intake. And now for the qualitative outcomes of fruit and vegetables. So this was about caregivers and children's perceptions and observations and experiences related to fruit and vegetable consumption, cooking, and trying new fruits and vegetables. They reported that there were positive shifts with children. About 62% of the participants increased fruit intake, and then 56% of participants increased green leafy vegetable intake. They also reported that they agreed to the statement, my child likes vegetables and my child likes fruit. They also reported that fruit and vegetables their children increased to eating 5+ servings a day, and that 80% of participants at the end of the program tried a new fruit and vegetable at every delivery. The themes seen across all qualitative articles were improved eating habits, new fruit and vegetables in the home, increased consumption of fruit and vegetables, accessibility to fruit and vegetables, which increased their food choices, and a decreased consumption of processed foods. Barriers that were seen between all qualitative articles were time constraints, not being able to get to the store in time before they closed, transportation, and then the healthy food options were of not great quality. And we also looked at the USDA dietary guidelines and if these were met. So there were significant increases in fruit intake in 1 study from 93 to 100%. There was significant increase in total fruit and vegetable intake from 66% of participants to 82% of participants meeting guidelines. In 1 study, few children met the USDA guidelines of vegetables, so they assessed intake at 1/4 cup, 1/2 cup, and 1 cup, and all of that showed significant increases. And then participation of participants from baseline to end a program who met the guidelines for vegetables. So at baseline, it was at 6% of participants, and then at the end, 21% met vegetable guidelines. Fruit started at 41%, but increased to 57%. And total fruit and vegetable increase from 5% to 20%, but there was no significant difference. And then last outcome was food insecurity. I thought this was important to note because they were of food insecure children. And 6 studies found significant improvements in food security. 4 studies found improvements, but still remained food insecure at the end. And those 4 studies that did not show significant difference also did not show a significant difference in total fruit and vegetable intake, total fruit and total vegetables. And then in one qualitative study, they indicated that prescription programs had been extremely helpful, particularly in times of need. So to conclude, FVPPs appear to be associated with modest improvements in fruit and vegetable intake among food insecure children and adolescents, though the effects vary between programs and outcome measures. Limitations to this review. It was one Master's of Applied Nutrition student did it. Articles with no results were not included. So I found about 2 or 3 articles, but I looked everywhere for the results and I could not find them. So I couldn't add them in. In the qualitative studies, there's obviously no quantitative data. It was just on children's and parents' experiences and observations. There was no control group found in 13 studies, so they could not determine causality in the rest. There were self-reported on fruit and vegetable intake and food insecurity. So this could have caused some inaccuracies in underestimating or overestimating. And then small sample sizes were included in 3 studies. But there were strengths, so it was conducted using the PRISMA guidelines and ELA checklist. There was a comprehensive database search to identify the same inclusion criteria across all articles. Observational conditions were seen in all articles instead of controlled trials. So this reduced information bias and selection bias and measurement errors. And studies were published in the last 7 years, so made it timely. So implications of research were comparison. Research studies need, I think, to do comparison and control groups, more randomized control trials, and interventions of engagement with FVPPs, also with nutrition education. Using 24-hour dietary recalls, this could help have a more accurate dietary report. And then also to examine, future studies need to examine how we can help children achieve and maintain these USDA guidelines. And for practice, by providing interventions within the healthcare system, FVPPs can help decrease the risk of chronic disease associated with obesity. Healthcare providers can identify the importance of fruit and vegetables prescriptions and the role they have on helping their patients increase fruit and vegetable consumption with fresh foods to increase health promotion and disease prevention. They also have a direct role in identifying if their pediatric patients are food insecure or they have a poor diet. Being able to connect them to community resources, interventions, and advocating for policies can support their access to healthy and fresh foods. And if you guys have any questions, please email me here. Thank you for listening, and here are my references.